the Kanski lecture series Eyelid part 5, and in this part we are going to discuss about the eyelid tumors, and we have discussed basal cell carcinoma and squamous cell carcinoma. Now we are going to discuss the keratoacanthoma. Introduction. Keratoacanthoma is a rare, rapidly growing but subsequently regressing tumor that usually occurs in a fair-skinned individuals with a history of the chronic sun exposure. Basically, it is a regressing tumor. It increases in size and then it involutes. And it present in a patient who has a history of the chronic sun exposure. Invasion and metastasis are rare. Histopathological examination reveal irregular, thickened epidermis surrounded by the acanthotic squamous epithelium. A sharp transition from the thickened involved area to the normal adjacent epidermis is referred to as a shoulder formation, and a keratin-filled carter may be seen. So you can see figure 2.22a. So this is a keratoacanthoma, a histopathology showing the irregularly thickened eosinophilic epidermis with a keratin containing cup and a well-marked shoulder formation. So you can see that these are the shoulder formation, and there is a keratin-filled carter, and there is a eosinophilic epithelium. B is showing the small nodule. C is showing the hyperkeratotic nodule, and D is showing the keratin-filled carter during involution. Diagnosis: a pink dome-shaped hyperkeratotic lesion develops often on the lower lid and may double or treble in size within weeks. So there will be the small nodule formation and there will be the hyperkeratotic lesion. But it will increase in size, and then growth then ceases for 2 to 3 months, after which the spontaneous involution occur when a keratin-filled carter may develop. Complete involution may take up to a year and usually leave an unsightly scar. Treatment involves the complete surgical excision with a margin of at least 3 mm or utilizing Mohs surgery. Radiotherapy, cryotherapy or local chemotherapy are sometimes used. So basically you are going to surgically excise the lesion with a normal margin of almost 3 mm mercury. We will discuss Mohs surgery in the coming topics. We can do radiotherapy, cryotherapy, and local chemotherapy are also used. Sebaceous gland carcinoma. So introduction. Sebaceous gland carcinoma is a very rare, slowly growing tumor that most frequently affects the elderly with a predisposition for females. It usually arises from the meibomian gland, although on occasion it may arise from the gland of Zeiss or elsewhere. So basically the sebaceous gland carcinoma occur in the gland's meibomian gland, and it's very important. We can misled as an ecclesion, but the ecclesion, whenever elderly female patient presents to you with the ecclesion, you must do the biopsy of the lesion because there can be the sebaceous gland carcinoma. Histopathology demonstrates lobules of cells with pale, foamy, vacuolated, lipid-containing cytoplasm and large hyperchromatic nuclei. So there will be the large hyperchromatic nuclei, and there will be the foamy cytoplasm. Vegetoid spreads refer to an extension of the tumor within an epithelium and is not uncommon. Overall mortality rate is 5 to 10%. Adverse prognostic features include upper lid involvement, tumor size of 10 mm or more, and duration of more than 6 months. So these are one of the common prognostic factors. If the upper lid is involved, it will have a more poor prognostic lesion, tumor size greater than 10 mm, and if the lesion is greater than 6 months. So we can see figure 2.23. So you can see sebaceous gland carcinoma. A is showing the histopathology, showing large cells with the large hypochromatic nuclei and vacuolated cytoplasm, and B is showing nodular tumor, and C is showing the spreading type. In contrast to the basal cell carcinoma and squamous cell carcinoma, sebaceous gland carcinoma occur more commonly on the upper eyelid, where meibomian glands are more numerous. There may be simultaneous involvement of the lower and the upper lid on one side, 5%. Yellowish material within a tumor is highly suggestive of a sebaceous gland carcinoma. So whenever there is a yellowish secretion with the tumor, you can it is a suspicion of the sebaceous gland carcinoma. So basically there are two types, nodular and spreading. The nodular we can present as a like a clasion, but a separating time present may present like a blepharitis. Nodular sebaceous gland carcinoma present as a discrete hard nodule, most commonly within the upper tarsal plate, and may exhibit yellowish discoloration due to the presence of lipid. It can be mistaken for a clasion. Spreading sebaceous gland carcinoma infiltrates into the dermis and causes a diffuse thickening of the lid margin, often with eyelash distortion and loss, and can be mistaken for blepharitis. Sebaceous gland carcinoma can be confused with a chronic or recurrent localized meibomian gland inflammation. Tip: sebaceous gland carcinoma can be confused with chronic or recurrent localized meibomian gland inflammation. So next is lentigo maligna or melanoma. So based on this, these are a pigmented type of carcinomas, and what is the difference is basically on the basis of the histopathology. Introduction. Melanoma rarely develops on the eyelid but is potentially lethal. Although pigmentation is a hallmark of the skin melanomas, half of the lid melanomas are non-pigmented, and this may give rise to the diagnosis difficulty. Features suggestive of melanoma include recent onset of pigmented lesion, change in the existing pigmented lesion, irregular margins, asymmetrical shape, color change, or a presence of multiple colors and a diameter of a greater than 6 millimeters. So anything which is suggestive of a carcinoma is that it is rapidly increasing in size, and it have an irregular margins, and it have a diameter of greater than 6 mm. There will be the asymmetrical shape, color changes, or multiple colors. Lentigo maligna or melanoma in situ. Intraepidermal melanoma or Hutchinson freckle is an uncommon condition that develops in the sun-damaged skin in an elderly individual. Malignant changes may occur with infiltration of the dermis. Histopathology show intradermal epidermal proliferation of the spindle-shaped atypical melanocyte, replacing the basal layer of the epidermis. Clinically, lentigo maligna present as a slowly expanding pigmented macule with irregular borders. Treatment is usually by excision. Nodular thickening and areas of irregular pigmentation are highly suggestive of the malignant transformation. So I told you, basically the lentigo maligna is based on the histopathological. Basically, they are atypical melanocyte that is replacing the basal layer of the epidermis. And one thing is that that it is a present as a slowly expanding pigmented macule, and treatment is with the excision. So you can see figure 2.24. It is a lentigo maligna of the eyelid. Histopathology showing melanoma cells proliferating within a basal layer of the epidermis. B is showing the early lentigo maligna, and C is showing the melanoma arising from the lentigo maligna. So melanoma, what is melanoma? Melanoma histopathology shows atypical melanocyte invading the dermis. So when the epidermis, when the dermis is also involved, then it becomes the melanoma. Superficial spreading melanoma is characterized by plaque with an irregular outline and variable pigmentation. Nodular melanoma is typically a blue-black nodule surrounded by the normal skin. Treatment is usually by wide excision and may include local lymph node removal. Early detection carries a good prognosis, and a surgical excision is often curative, but long-term survival for the patients with metastatic disease is poor. Radiotherapy and chemotherapy are of limited efficacy, but no new approaches using immunotherapy are showing considerable promise. So as this is a spreading tumor melanoma. So what you do is not only excise the tumor, you also remove the local lymph nodes with it. So one thing that is very important in this. So let's see figure 2.25. It is showing melanoma. A is showing histopathology showing melanoma within dermis. B is showing the superficial spreading melanoma, and C is showing the nodular melanoma. That is the Merkel cell carcinoma. Merkel cells are a form of sensory receptor concerned with the light touch. So these are receptor which are concerned with light touch. Merkel cell carcinoma is a rapidly growing, highly malignant tumor that typically affects older adults. Its rarity may lead to difficulty in diagnosis and delay in treatment, and 50% of the patients have a metastatic spread by presentation. Histopathology show a sheets of Merkel cells, a violaceous well-demarcated nodule with intact overlying skin is seen, more frequently involving the upper eyelid. Treatment is by excision, often with an adjuvant therapy. Adjuvant therapy can be radiotherapy or chemotherapy. So you can see figure 2.26. A is showing the histopathology showing sheet of Merkel cells, and B is showing the clinical appearance. It is nodular in shape. So Kaposi sarcoma is also very important. Basically, AIDS patient present with Kaposi sarcoma, and it is a purplish lesion, and it is one of the tumors that is more sensitive to the radiotherapy. Kaposi sarcoma is a vascular tumor that typically infect individuals with AIDS. Many patients have advanced systemic disease, although in some instances the tumor may be the only clinical manifestation of the human immunodeficiency virus infection. Histopathology show proliferating spindle cells, vascular channels, and inflammatory cells within a dermis. Clinically, a pink, red, violet, or to brown lesion develops, which may be mistaken for a hematoma or nevus. Treatment is radiotherapy or excision and by optimal control of AIDS. So basically, what is in the histopathology? There are going to be spindle sheath cells, vascular channels, and inflammatory cells. So let's see figure 2.27A and B. So 2.27A is showing Kaposi sarcoma. A is showing histopathology showing the proliferation of the predominantly spindle shaped cell, vascular channels are evident. B is showing the clinical appearance. Treatment of the malignant tumors. Biopsy. So one of the thing is biopsy can be either incisional using a blade or a biopsy punch in which only the part of the lesion is removed for histological diagnosis, or excisional in which the entire lesion is removed. The latter may consist of a shave excision using a blade to remove a shallow epithelial tumor such as papilloma or seborrheic or full thickness skin incision for tumors that are not confined to epidermis. So there are two types of biopsy, incisional and excisional. So in excision, only the part of the tumor is removed for the biopsy purpose, and in excision, whole of the tumor is removed for the histopathological purpose. Incisional biopsy is usually done for very large tumors, and excision is for the very small tumors. So one of the main treatment of the tumor is the surgical excision. Surgical excisions aim to remove the entire tumor with preservation of as much as normal tissue as possible. So one of the thing of the main principle of the tumor excision is that you must preserve as much as the normal tissue as possible. Small tumors can be removed by an excision biopsy and defect closed directly while awaiting histological confirmation of the complete clearance. So whenever there is a small tumor, you can just simply excise them and then close the defect directly, and then send the tissue for biopsy. Most small BCC can be cured by excision of the tumor together with a 2 to 4 millimeter margin of a clinically normal tissue. So whenever you see you suspect some kind of malignant tumor, you can you must remove the tumor and along with the normal margins of almost 2 to 4 mm. More radical surgical excision is required for a large BCC and aggressive tumor such as squamous cell carcinoma, sebaceous gland carcinoma, and melanoma. It may not be possible to close the defect at the time of initial removal, but it is necessary to ensure complete clearance of the tumor prior to undertaking any reconstruction. There are several options for the coordination of the histopathological diagnosis and the tumor clearance with excision. So one of the main problem is that sometimes the tumors are very large. So whenever the tumor, for example, the tumor is covering around the half of the eyelid, so what can you do? You must remove all the tumor along with the 2 to 4 mm margin, and after that there gonna be a large defect that needs to be closed. So for that purpose we need a reconstruction surgeries, and you can do on the same day after the you are confirmed that the margins are clear of any tumor cells, or you can delay the procedure until the confirmation of the histopathology. So there are several methods that can be do for the histopathological diagnosis. So there are conventional paraffin embedded specimen. Rapid processing can reduce the interval to confirmation of the histological clearance, but still requires the reconstruction to be performed as a separate procedure. Faster confirmation can be achieved using either frozen section control or micrographic surgery, and reconstruction then take place on the same day. So one thing you can do is that you take the sample and then send it for the paraffin embedded specimen. So for the paraffin embedded specimen, you delay the reconstruction until you have the histopathological evidence that the margins are clear of the tumor. So it is done on the separate day, or it is a separate procedure. The reconstruction is a separate procedure. But if you want if the you want to do the procedure on the same day, like you excise the tumor and you want to reconstruct on the same day, you can use either a frozen section or the Mohs micrographic surgery. It is a relatively faster procedure. Standard frozen section involve the histological examination of the margin of the excised specimen at the time of surgery, so that they ensure that they are tumor free. If no tumor cells are detected, the eyelid is constructed on the same day. However, if the residual tumor is present, the further excision is performed at the appropriate edges of the surgical site until no tumor is detected. So what you do is, when you remove the large tumor, and what you do is you see the edges of the excised tissue, that is that free of the tumor cells. If that is free, then you can just close the defect on the same day. But if it is not, you excise that portion more, and then you confirm it again with the histological examination. If it is free, then you reconstruct the eyelid. Most micrographic surgery involves the layered excision of the tumor. Specimens are usually examined frozen. Processing of each layer depends on a map of the edges of the tumor to be developed. Further tissue is taken in an area where tumor is still present until the clearance is achieved. Although time consuming, this technique maximizes the chance of the total tumor excision while minimizing sacrifice of the normal tissue. This is particularly useful technique for tumor that grows diffusely and have an indefinite margins with a finger-like extension, such as sclerosing BCC, squamous cell carcinoma, recurrent tumors, and those involving the medial and the lateral canthi. The irregular contour along the eyelids and the extension of the tumor into the orbital fat can make the interpretation difficult. So for the Mohs micrographic surgery, basically it is for the depth of the tumor. For example, the tumor is you cannot see the tumor more on the lid margin, but it is very deep inside. For that procedure, we do the Mohs micrographic surgery. So you excise the deeper portion of the lid, and then you see that are the edges free of the margins. If they are not, then you excise the more, you do the layered excision more. And just this procedure just help that to preserve the normal tissue as much as possible. So reconstruction. So now we send the patient for you excise the tumor, and then you do the histopathological evidence, and now you have a large defect to reconstruct. So how will you reconstruct the defect? The technique of reconstruction depends on the extent of the tissue removed. It is important to reconstruct both the interior and the posterior lamellae, each of which must be reconstructed with with similar tissue. Anterior lamellae defect may be closed directly with the local slab or skin graft. Options for the repair of the full thickness are set out below. So let me just explain that the eyelid margins are divided into anterior lamina and the posterior lamina eyelids. So the interior lamella consists of the skin and the orbicularis muscle, and posterior lamella consists of the tarsus and conjunctiva. So for the reconstruction of, when you remove the whole of the eyelid from the interior lamella, posterior lamella, you have to bring the tissue as well. So for the interior lamella, we make the skin graft, or we do the flap, we take the flap. Whereas for the posterior lamella, we can use the mucosal membrane or anything related to the posterior lamellae. Now one thing very important is small defect, medium defect, and the large defect. So if it depends upon the after excision, like you remove the tumor with the 3 mm of margin, how much the defects remain. If it is less than 1/3, you can just close it. If it is less than 1/3, you can close this directly, or you can also do some plus minus canthotomy or cantholysis with it. If it is greater than 1/3, but almost less than half, so you can also do the uh, tensile semicircular flap closure. And for the larger defect, that is for the large defect like greater than one half of the eyelid, then we are going to do either the, depending on the upper eyelid and lower eyelid, we do the procedures. Small defect involving the less than 1/3 of the eyelid can be usually be closed directly, provided the surrounding tissue is sufficiently elastic to allow approximation of the cut edge. If necessary, a lateral cantholysis can be performed for increased mobilization. So these are usually the defects that remain after the excision of the tumor with the normal margin as well. So you can close this directly. B is moderate size defect involving up to half of the eyelid may require a flap, that is a tensile semicircular flap for the closure. So for the medium size, we do the semicircular flap from the lower eyelid. We can take the skin from here or from there. So these are the semicircular flap. Large defect involving over the half of the eyelid may be closed by one of the following techniques. So whenever there is a very large defect, you have to replace it with the posterior lamellae or interior lamellae. And one of the principle is that one of these must have its own blood supply. Posterior lamellar reconstruction may involve an upper lid, free tarsal graft, buccal mucous membrane, or a hard pellet, or Hughes tarsoconjunctival flap from the upper lid, which is left attached for the 4 to 6 weeks before transection. Anterior lamellar reconstruction may involve the skin advancement, a local skin flap, or a free skin graft. The patient may be aware that the grafted skin is unlikely to be a perfect match. At least one reconstructed lamella requires its own blood supply to maximize the visibility of the free graft component. So in this topic, what we have to understand is between the flap and a graft. So graft is you take that part from somewhere else. Somewhere else mean that is not associated around the eyelids. The flap is a portion which is around the eyelid. So for example, you have excised the tissue, and there you mobilize the surrounding skin, then it is a flap. But if you take the flap from somewhere else, like from the back, upper arm, then it is called the graft. So one thing it is this. So another thing is that, if you are doing both reconstruction, interior lamina or posterior lamina, one must have its own blood supply. For example, if you are taking the skin flap, then you can take the buccal mucous membrane graft, or anything else, hard pellet. But if you are not taking the skin, if your skin you are taking the skin graft from the somewhere else, then you can only do the tarsal, upper lid tarsals, conjunctival tarsal flap. So one must have a flap as well. And the posterior lamellar reconstruction, you can take the tarsal graft from the upper eyelid, and buccal mucous membrane graft, a hard pellet, or a tarsoconjunctival flap from the upper lid. So let's see figure 2.28. So it is a direct closure, so which is less than 1/3 of the eyelid. Preoperative appearance of the basal cell carcinoma, showing lid marking. B is showing the first cut at the right angle to the margin. C is showing the excision of the pentagon and a first suture at the posterior lid margin. D is showing the tarsal plate closure with the lid margin in situ. So these were the tumor, and you do the pentagon type excision, and then you close the defect directly. Basically the principle is that. Next is the medium sized graft, and you can see the tensile flap, which is a semicircular flap. A is showing the incision mark and excision of the tumor. B is showing the flap reflected deep, flap reflected deep to the orbicularis and cut lower limb of the lateral canthal tendon. Flap edge fixed to the fixed to the opposite limb of the lateral canthal tendon, and eyelid defect and flap closed 6 months after surgery. So what is you do is you have excised the tumor, and it is about almost 1/2 of the lid, but not greater than 1/2, and you do the marking is like semicircular flap. You excise the flap, and you retract it, and you also do canthotomy and cantholysis. After that, what you do is that you take the flap, and you do both, you cover the defect with the you cover the defect of the eyelids, and then you place the semicircular flap again. So this is after the post surgery. So 2.30 show the posterior lamellar reconstruction with the Hughes upper lid flap. A is showing the lower lid defect. B is showing the tarsoconjunctival flap cut and turned into the defect. Molar muscle separated from the superior tarsal border. C is showing the tarsoconjunctival flap sutured to the defect. Anterior lamellar reconstruction with a full thickness graft from the upper lid. Division of the conjunctival pedicle 3 months after the surgery. So one is in this procedure, these are called the Hughes tarsoconjunctival procedure, and it is done for the lower eyelid when the defect is greater than half of the lid. So what you do is you take you excise the conjunctiva and the tarsal from the upper lid, and then you suture it with the lower lid posterior lower lid margin in the posterior lamina. After that, what you do is you take the skin graft. You can take the skin graft from the upper lid, you can take from the upper armpit, or you can take from the back as well. So what you do is that you take the, why it is called this is a flap and this is a graft. Why it is a graft? Because it has lost its blood supply, because it is taken from the other side, but the flap is still attached to the upper lid. It is just excised from the upper lid but still attached at the upper lid, and you just attach it here in the lower lid. After that, what you do is that as you it, make it attached for at least the period of 4 to 6 months, 3 months. And then what you do is that when the healing occurs, you can just excise the tarsoconjunctival graft that was from the upper lid, and then this is the post surgical procedure. So next is the Lassie's-Farey procedure. Full reconstruction of the defect created by the tumor removal may not always be required. So full reconstruction of the lid defect created by the tumor removal may not always be required. In the Lassie's-Farey approach, the wound edges are approximately as far as possible, and the defect is allowed to granulate and heal by the secondary intention. Even large defects can often reach a satisfactory outcome in time. So this is one of the very common procedure that we do even in the case of trauma, that whenever there is a large defect, what you do is that you try to approximately as much as possible and leave the rest for the secondary intention. For and secondary intention is that it heal itself and granulate and form the skin. So this is the Lassie's-Farey procedure. Radiotherapy, the recurrence rate following irradiation alone is higher than after surgery, and radiotherapy does not allow histological confirmation of the tumor eradication. Recurrence following radiotherapy are difficult to treat surgically because of the poor healing properties of the irradiated tissue. Indication: patient who are either unsuitable for or refuse surgery, highly radiosensitive tumors such as Kaposi sarcoma, adjuvant therapy, in some cases palliative treatment. So basically, indication of the radiotherapy is that whenever the patient is not suitable for the surgery candidate, and radiosensitive tumors such as Kaposi sarcoma, it is used as an adjuvant therapy, like after surgical excision. Still for the remaining tumor, or to prevent recurrences, we do adjuvant therapy. You can do palliative treatment. Palliative treatment mean the tumor is non-curable, but you just do radiotherapy to reduce the size to have a less symptoms as compared to that with other without removal. Relative Relative contraindication include medial canthal lesion due to high probability of the lacrimal glandular damage, upper eyelid tumors, conjunctival keratinization is common and difficult to manage. Aggressive tumors such as sebaceous gland carcinoma are relatively radioresistant, but higher dose treatment may be effective. Complication: many of these can be minimized by appropriate shielding, skin damage, and medarosis. Nasolacrimal duct stenosis following irradiation to the medial canthal area, conjunctival keratinization, dry eye keratopathy and cataract, retinopathy, and optic neuropathy. So these are the complications that can be associated with radiotherapy. One must can have a lacrimal damage, dry eyes, cataract formation, optic neuropathy, and retinopathy. Cryotherapy may be considered for a small superficial basal cell carcinoma and can be useful adjunct to surgery in some patients. Complication includes skin depigmentation, medarosis, and conjunctival overgrowth. So basically, you use the freezing method to remove the tumor, and it is basically used as an adjunct therapy. That is, after the surgical removal, you do it to kill the remaining micro-sized tumor cells. So that's it for the eyelid part 5. See you in the next lecture.